Thank you, Chairperson. I'm thankful for the organizers for inviting me for this talk and in this such a wonderful meeting. So the task allotted to me is the role of newer test of population in guiding the transfusion practices in patients with acute variceal bleed. So the outline of my talk includes the acute variceal bleed in cirrhosis and its relation to coagulation, newer test of coagulation in cirrhosis, the transfusion practices for acute variceal bleed in relation to newer test of coagulation during the initial resuscitation of acute variceal bleed, failure to control bleed, and preventing the post-eval ulcer-related bleed, and my proposed algorithm. So the bleeding in cirrhosis has many phenotypes. The most common is the bleed related to the rupture of the esophageal varices due to secondary to raised portal pressure, and this is the most common cause of acute. This is the variceal bleed where very high mortality. Other phenotype of bleed in cirrhotics is the so-called coagulation-related bleed, which may be spontaneous, unprovoked bleed due to bleeding from the skin and the mucosa, as well as sometimes the deep hematomas and hemoperitoneums. And in these cases, most of us usually give coagulation factor corrections. Then the other sort of bleeding is the intervention-related bleeding due to inherent risk of the procedure itself, as well as due to the injury to the vessel wall, as well as the coagulation failure. So, interestingly, all these types of bleed are increased in patients with acute kidney injury, presence of bacterial infection, and ACLF. So, these patients have the precarious coagulation balance and they tend to bleed. In a previous study, the patients who had acute variceal bleed cirrhotic on anticoagulation at the time of bleed were compared with those who had no anticoagulation at the time of bleed. There was no difference in the 5 days treatment failure or severity of bleed. Moreover, a large prospective study published in Gut had shown that the thrombin generation is normal in cirrhotic patients with acute variceal bleed. So the data suggests from the literature that esophageal variceal bleeding is a mechanical issue due to secondary to portal hypertension, and it is not a coagulation issue. So management of the acute variceal bleed includes the timely antibiotic therapy, careful volume depletion with restricted therapy, restricted hemoglobin target of around 8, and the use of splenic vasoconstrictant to decrease the portal pressures, terlipressin, preferably otherwise somatostatin, and the therapeutic endoscopy as early as possible with endoscopic band ligation or glue therapy in gastric variceal bleed. Some of the patients with failure to control bleed or unmanageable bleed, the rescue tips may be handy. The proposed the latest development criteria has suggested that there is no role of FFP transfusions in acute variceal in the setting of acute variceal bleed. There is no role of platelet transfusion, and there is no role of tranexamic acid use in acute variceal bleed. However, in patients, they also suggested that however in cases of failure to control bleed or very difficult to control bleed, the decision to correct the hemostatic abnormalities should be considered in the case-to-case basis, very low degree of criteria. So my thinking is that in patients with uncontrolled acute variceal bleed, we have to prevent the bleeding which is occurring due to high portal pressure to the bleeding which occurs due to hemostatic failure. Because in uncontrolled variceal bleed, there is the consumption of the coagulation factors. If we give too much volume with too much crystalloid, too much PRBC, then there is a dilution of the coagulation factors. Moreover, in the due course with uncontrolled bleed, there is tend to become bacterial translocation, sepsis, post-bleed severe anemia, acute kidney injury, hyperlactatemia. All these lead to worsening of the coagulation parameters and perpetuation of the bleeding, and thereby converting the mechanical and portal hypertensive bleed into a crisis with bleeding due to hemostatic failure. Now, there are certain evidences where we can say that the variceal bleed may be due to maybe due to local hemostatic failure. As you can see here, in 5% of the patients with acute variceal bleed, they form a white nipple sign. So white nipple is actually a local hemostatic mechanism. It is a fresh, highly permeable plasma-rich, platelet-rich clot without RBCs. And this is very high at the site of the rupture of the varices. And this is very high chance that once inadvertently this may rupture and lead to the very massive bleeding. So local hemostasis, which are achieved at the site, is destroyed with the certain endoscopic effort. Another pair of studies have shown that the low fibrinogen level is associated with the high risk of bleeding in either after EVL in patient with thrombocytopenia and cirrhosis. So these studies have suggested that the coagulopathy may play a role. Moreover, the many guidelines suggest the coagulation correction in acute variceal bleed. The British guidelines suggest the platelet transfusion should be given in actively bleeding varices and platelet is less than 50,000. And fibrinogen correction should be done. The FFP correction should be done. The endoscopy guidelines also suggest that the platelet and coagulopathy correction should be done in patient with acute variceal bleed. So there remains a lot of dilemma. So now, how do you test of coagulation in cirrhosis and what is the extent of their use? So we do the test of coagulation because standard test of the coagulation like the INR, APTT, platelets, fibrinogen, because only the anti-hemostatic drivers due to deficiency of the procoagulant factors and the low platelet count, high TPA, and fibrinolysis. But in the patient with cirrhosis, there is always rebalanced hemostasis because of the activation of the endothelium-derived clotting factors, factor 8, as well as high volume factor, which increase platelet adhesion, as well as the anti-coagulant factors like the protein C, protein S, and antithrombin. So there is always a balanced precarious hemostasis in a patient with cirrhosis. Moreover, the real test of coagulation test in the whole blood. So whole blood, there is always the RBCs as well as the platelets and all these factors. So the whole blood test measures actually the patient hemostasis, but INR prothrombin and measurement measure the plasma hemostasis. So the test like the viscoelastic test, the thromboelastography, rotational thromboelastometry, and the sonoclot assay are point of care tests, especially the ROTAM assay is very point of care test. Assay time is 2 to 4 minutes. And the analysis of the viscoelastic test like the ROTAM or tag is very easy. Once we have the R time donates the time taken for the initial clot initiation. So reaction time is increased, then we need to give the FFP. The more reaction time increase, more FFP to be given. Then K time is the time taken for the achievement of a certain clot firmness, like from 2 millimeter clot to 20 millimeter clot. Then there is an angle which suggests the kinetics of the clot development. That the maximum amplitude in the tag and the maximum clot firmness in the ROTAM suggests the maximum clot strength, and the lysis time 30 minutes after the maximum clot strength suggests the fibrinolysis part, and we need to give the tranexamic acid in these scenarios. So what we see normally in the patient with cirrhosis, especially in the patient with advanced cirrhosis, the normal coagulation parameters like the INR platelets are but there is a normal viscoelastic test like ROTAMs in these patients, and thereby we can prevent a lot of transfusions. In fact, the meta-analysis based on the randomized study was published recently, which has shown that the thromboelastography-based therapy enhances the blood management in these patients with cirrhosis. There is less transfusion requirements in those patients who are managed on tag-based guidance. However, it is still not what is the abnormal tag, how much to correct, there is no standard guidelines, and when to repeat the tag, does the tag prevent mortality, does the tag prevent the rebleeding rates? So these are the questions remaining to be answered in the future studies. Now coming to the transfusion practices for bleed, especially in reference to the test of the coagulation. So in a patient with acute variceal bleed, especially in those with massive bleed, we have to manage the volume very precisely. Because when we research these patients, there is a relationship between the total rise in the total pressure as well as the vascular volume. So if we over transfuse by giving the more RBCs, more FFPs, then there is always a chance of worsening of total pressure and leading to rebleeds, platelet control bleed, and there is a risk of the volume overload. Under transfusion has its own demerits leading to lactic acidosis, hypovolemic shock, and development of multi-organ ACLF. So do we really need to fix the INR in these patients? Actually, we cannot fix the INR in these patients practically because the FFP dose requirement is very high. Suppose the initial INR is 3 and our target INR is 1.5. then we need to give 2 liters of FFP in these patients, which is equal to around 10 units of FFP, which is practically impossible in a patient with acute variceal bleed. This leads to balloon overload and risk of trolley and the rebleed rate. And this has been shown in a recent study that the massive transfusion of FFP in a patient with acute variceal bleed lead to very high mortality, failure to control bleed, and prolonged length of the stay. Moreover, giving plasma in a patient with cirrhosis has no major effect. It has no effect on the thrombin production as compared to the controls. Now, what about the platelets? The studies based on the thrombin generation assays have shown that the platelet count of 56,000 is enough to maintain the thrombin, which is derived from the platelet. So, but the thrombin generation assay is not a good marker for the prediction, the platelet function test. If we give the small volume of the platelets in the patient, then there is no increase thrombin production by using the thrombin generation assay. But if you use the choroidal analysis in these patients, then there is an increase in the clot firmness in these patients. So giving platelets in patients lead to improvement in the clot firmness as detected by the rotum, which is quite sensitive. Moreover, the recent studies from AIMS have shown that this is a randomized controlled trial in patients with cirrhosis with acute variceal bleed with coagulopathy, suspected coagulopathy, INR more than 1.8 and platelet less than 50,000. The tag correction has lead to lesser requirement of FFP and platelet transfusions, but there was no improvement in the control of bleed, rebleeding at 5 days and mortality at 6 weeks. In a patient with cirrhosis with very advanced liver disease, especially in ACLF, there is sepsis, there is a association development of the formation of the heparin-like factor endogenous heparinoids, which worsen the coagulation, the reduction in the factor 7, factor 13, and secondary fibrinolysis, which lead to DIC-like situation and massive bleed. So we can carefully correct in some of these situations by using careful like HEPTAM, which corrects for the heparin production, FIPTAM, which corrects for the fibrinogen. So we can determine which type of abnormalities there and thereby correcting these measures. Recently we did randomized controlled trial at ILBS, where we used in a patient with acute variceal bleed, the tranexamic acid versus placebo. The tranexamic acid was used in the initial 30 minutes, then 3 grams of infusion after 24 hours. But the tranexamic acid as compared to placebo lead to no improvement in the failure of control bleeding, 5-day treatment failure, mortality, and the transfusion requirements. However, the subgroup analysis has shown that the patient with baseline fibrinolysis had the better 6-week rebleed rate with tranexamic acid. Now, the bleeding part is controlled. We need to do the endoscopic band ligation. The studies have shown that the tag is not helpful, and we should not correct these patients before endoscopic band ligation, despite the raised INR and the platelets. There was no difference in the tag parameters in those who developed the post-evil ulcer bleed as well as no rebleeds. So this is my suggested algorithm. So once a patient is suspected acute protein hypertensive bleed, we should have to determine the severity of the bleed, plus the active and controlled bleed in emergency. In 30 minutes of the time, we should give antibiotics. The CLF patient with high risk of infection give carbapenems, and etablation should be preferred if contraindication by somatostatin. Initially, prescribed correction should be started, and send the baseline tag and blood products. Restricted transfusion policies with hemoglobin target of 8 should be maintained. In patient with massive bleed requiring very high PRBC transfusion requirement, then we should do the tag-based correction. You give platelets, cryo. Cryo should be referred to FFP due to low volume. If the tag shows hyperfibrinolysis, then tranexamic acid with infusion should be given simultaneously. Then if the endoscopy should be done as early as possible after control of resuscitation, and control of bleeding, if there, then it should be done after 3 weeks with no tag and no FFP and platelet transfusion. If there is failure to control bleed, then these patients are very sick, and these patients will require salvage therapy in form of PIPs or BRTO. or misunderstand, and we think this correction should be done, and it is still not how often to repeat the tag and how often to correct, and what are the targets. We need future study for this. Thank you for the kind attention.